since 2016. And the aim of the project is to identify the capnography gap in low-income countries, to provide education and training on capnography, and provide equipment, obviously, and follow up then to see whether our education worked and whether the equipment was suitable for that environment. And our first project was in Malawi, and we brought equipment donated by GE to Malawi and taught mainly non-physician anaesthetists. And we used the training package that's been developed in Bath by Tim Cook and Fiona Kelly on caps as hats. It's a very simple way of explaining the capnography traces. We went into the theatres, we helped them set them up. And then we came back 6 months later. They all kept logbooks. We audited the number of reported esophageal intubations they found, and the results were quite staggering in that they reported 44 esophageal intubations, and 90% believed that capnography had saved lives. They loved this equipment because for the first time they could kind of confirm that their tubes were in the right places. And we wrote up that QI project. It was published in Anesthesia. And then we started to do a pilot in Uganda, but unfortunately COVID hit. But what we're hoping to do is to raise some money to develop these educational packages to start looking at low-cost capnography, and that's ongoing, so we can provide these settings with capnographs. I think it'll save so many lives. We estimate that 11,000 fatal anesthesia accidents could be prevented in sub-Saharan Africa by extrapolating the figures we got from a whole country, which was Malawi, which has a population of 7.5 million. So it's a plea really for people to help maybe with the teaching, but also some donations to help us progress this. I think it is essential. And as I say, they really, really saw the benefit. And as I said, these were mainly non-physician anaesthetists.
Thank you, Ellen. Really, really, really important project. To our viewers, please, and listeners, please consider supporting this really vital project. As people that care about airway, I think that we should be caring about airway no matter where it happens. And the global capnography project is absolutely crucial. We're coming a little bit short on time, but I really want to bring in Sheila because one of the things that's been highlighted repeatedly, and we talk about this at our meetings, and it's been highlighted throughout the guideline, was the role of the airway assistant, and how do we actually go about empowering airway assistants to actually be facilitators of safe care?
Right. Thank you very much, Karim. This is a very important question, and I'm very happy that our guideline has touched on this. We all talk about this at meetings, but no guideline has specifically emphasized the role of the airway assistant, and I think this is really important. As we know, airway management is a team sport. It may not always be possible in all settings to have an airway assistant, but the guidelines emphasize that you should try to have an assistant, and the assistant should be actively involved in observing the view using the video laryngoscope, as well as confirming sustained exhaled carbon dioxide and adequate saturation. Now, if you want to have your airway assistant, being part of the team, this airway assistant has to have both expertise and also has to be empowered. Now, coming to expertise, the assistant can't just be somebody who's just handing over equipment to you. This person has to be trained. And I think the best way to do it is not only specific training in this area, but also daily practicing this as part of teamwork, where you're discussing and you have a shared model and you're talking about this. So you use this, you practice this daily in the operating room along with your airway assistant, so that whenever you actually, have a problem, they're really able to help you and they have the expertise to do this. And the second aspect is more important. That's about empowerment. And I think it's very important that the entire team should be empowered. And this requires a culture change. So it's about flattening the hierarchy. So every member of the team, your assistant, should be empowered to speak up if there's a problem. And this is very important to bring out this change. So all this involves, training, education, simulation-based training, and other aspects of training, and also empowering the the airway assistant, and training them. And it's really nice to see that the UK College of Operating Department practitioners, and also the New Zealand anesthetic technicians, their associations are also supporting these guidelines. So I think this is a step in the right direction, to empower the airway assistants.
Thank you, Sheila. I obviously couldn't agree more, and I actually really hope that we can all get the paper in the hands of all of our assistants, and get them to read the paper as well, because having
Right.
them learning in the exact same manner that we are will really flatten that hierarchy and really get us all to learn together. And I've probably got time for just one more question, and I think this is a really poignant question, which is using clinical examination and clinical signs. And I'm going to end this probably with a question to Andy, because the guideline is pretty firm in that it condemns the use of clinical examination to exclude esophageal intubation. And this is a really significant change from traditional teaching that most of us might be resistant to. I mean, we've all been raised to say, look for the misting and look for the chest rising. But how could you persuade us to not use those clinical examination tools?
Well, thanks, Kareem. This is a vital point. It actually seems to have bypassed many of us, including me. I think over the years of how ineffectual and how inaccurate clinical signs are. When you read the coronial reports, as we've done for these cases, and some of us have medical legal practice, almost all the cases in which the patient dies or sustains really bad brain damage, there is always a line where the clinician involved says, yes, I heard breath sounds, or the tube was misting, the chest rose when I squeezed the bag, there were no epigastric gurgling or anything like that, there was no abdominal distension. There are all these different clinical signs, but one of the common themes of all the catastrophes is that someone says the clinical signs supported the diagnosis that the tube was in the trachea. And we've known for over 30 years that that's not true. Here in August in the UK, we're taking our new batches of new trainees, and we're teaching them on their basic laryngoscopy skills. And I've had it this week in theatre that people have told me that they've put a tube in, and the tube is misting and the chest is rising. And I say to them, well, okay, if the tube is misting and the chest is rising, but the CO2 is inadequate, what are you going to do? And they say, I'm going to take the tube out. And if I say, well, if there wasn't any misting and the tube wasn't rising, but you could see a rise in the CO2 with exhalation and a fall with inspiration, what would be your conclusion about where the tube was? And they would say, it's in the right place, I'm going to leave it. So why do people, why do we focus on this? I think it's a function of our training, but I think that the fact that our trainees will routinely pop a tube in and then say the tube is misting and the chest is rising, it tells us two things: A, that we've been teaching what essentially has become airway mythology, and that is evidence based. But the other thing is that we've proven to ourselves that we can teach our trainees and we can teach ourselves to actually verbalize something when we put a tube in, and that's very useful. So what I think we should move to is a situation where people are putting tubes in, and instead of saying the tube's misting and the chest is rising, they should say something akin to what we say in the guideline, which is, I can see sustained exhaled CO2, good SATs, do you agree? And engage the airway assistant, include them, and actually give them the opportunity to challenge whether or not they think they agree. And that's how airway management, goes from the me to we, and that's how we should avoid it. Incredibly important that we should not rely on clinical signs.
Here's the simple thing on clinical signs, Kareem. In all the cases that we looked at for the guideline, in every case of unrecognised esophageal intubation, where they listened for breath sounds, they heard them every time.
Yeah. Incredibly common
Yeah.
in children as well. You can hear breath
I
sounds in
think
children. And in the chaos of a failed intubation where the patient is going off, it's very, one of the problems is crowd control. Actually, I defy anyone to properly hear breath sounds when the theatre or the emergency room is beginning to fill with patients because there's some disaster evolving. It's really, really tricky.
I do wish that I had the power to mute other people at times, but unfortunately, I think I'm going to need to draw this really, really crucial event to a close. There's been some really vital points. We covered a lot of ground. There's been a lot of important discussion here, but I think that, as I said before, this discussion should really be a stimulus for us to actually spend a little bit of time reading and digesting the contents of that paper. I want to thank all of my panel. I really want everyone to recognize as well that George has been here the whole time, but he has claimed that it's been a plot against emergency medicine. However, there's also been technical issues with Tim as well. So I think it's a plot against all of us to a certain degree. However, I'm really grateful to all of you for your time. Thank you for joining me. I want to point everyone in the direction of the guidelines. You can use the QR code there that appeared and disappeared to read the paper. It's free. There it is again. It's free and it will be forever. Please do consider supporting the Global Capnography Project. The QR code will be up in just a second. I'd like everyone to continue this discussion and use the hashtag #musthaveCO2 if you can as well. And the Twitter handles for all of the speakers here will be available, and we will continue this discussion on Twitter afterwards. So without further ado, I thank you all for your time. Must have CO2. Please do join the conversation and pick up the paper and change what we all do with all of our patients today. Thank you very much, everyone, and very good morning, good afternoon, or good night.